Acute kidney injury and chronic kidney disease. Acute kidney injury, that is AKI. Acute impairment of kidney function. Definition: serum creatinine and urine output. Serum creatinine absolute increase more than 0.3 milligram per deciliter over 48 hours. Serum creatinine more than 0.3 milligram per deciliter over 48 hours, and relative increase 1.2, 1.5 to 2 times over from baseline in 7 days. 1.2 to 2 times from baseline over 7 days. Urine output decreased to less than 0.5 milligram per kg per hour for more than 6 hours. Urine output decreased less than 0.5 mil per kg per hour for 6 hours. AKI staging. Stage 1, 2 and 3 acute kidney injury. Stage 1, 2 and 3 AKI. Stage 1, you have your increase of serum creatinine of 0.3 milligram per deciliter over 48 hours or more than equal to 1.5 to 2 fold from baseline in the last 7 days, and urine output is less than 0.5 ml per kg per hour for more than 6 hours. So this is your criteria for stage 1. Now stage 2, this is more severe. So 1 to 2 to 3 fold from baseline. Serum creatinine is increased. Less than 0.5 ml per kg per hour for more than 12 hours. Urine output is decreased. Third is 3x from baseline. 3x increase from baseline on return absolute serum creatinine more than 4 ml per deciliter or patient undergoing dialysis, or EGFR less than 35 ml per minutes per 1.73 meters square. So 3x increase from baseline serum creatinine, that's 3 times creatinine. Absolute serum creatinine more than 4 milligram per deciliter. So anytime the serum creatinine is more than 4 milligram per deciliter, then it is called absolute serum creatinine more than 4 milligram per deciliter, that is stage 3. Patient undergoing dialysis, or EGFR less than 35 ml per minute per 1.73 meters square. Urine output less than 0.3 ml per kg per hour for more than 24 hours. So for more than 24 hours, urine output is less than 0.3 ml per kg per hour, or there is no urine and urea for more than 12 hours. Swartz formula. EGFR, length of child in centimeter into K constant upon serum creatinine milligram per deciliter. What is EGFR? Length of child in centimeter into K constant upon serum creatinine in milligram per deciliter, where K is 0.413, where K is 0.413. Drawbacks of using serum creatinine for staging. What are the drawbacks? It is age dependent. Value of serum creatinine varies according to muscle mass. Delayed rise in serum creatinine following AKI. There is a delay of acute kidney injury and then rise in serum creatinine. Unreliable due to absence of previous base value. There is no previous base value, so it is unreliable. Newer biomarkers to overcome drawbacks of serum creatinine. What are the newer biomarkers to overcome the drawbacks of serum creatinine? It is cystatin C. Newer biomarker is cystatin C, neutrophil gelatinase associated lipocalin, ANGEL, neutrophil gelatinase associated lipocalin, and kidney injury molecule KIM1. Kidney injury molecule 1, KIM1. Etiology. Pre-renal causes most common. Renal causes and post-renal causes. Pre-renal causes most common is due to decreased perfusion to kidney. What are the pre-renal causes which causes decreased perfusion to kidney? Is dehydration, shock, hypovolemia, cardiac failure, third spaces loss in sepsis and nephrotic syndromes. Renal causes: acute tubular necrosis, decreased perfusion, ischemia, and then necrosis. acute tubular necrosis, decreased perfusion, ischemia and necrosis, glomerulonephritis, hemolytic uremic syndrome, HUS, hemolytic uremic syndrome, HUS. Post-renal causes due to obstruction. Renal causes is acute tubular necrosis, glomerulonephritis, and hemolytic uremic syndrome, HUS. Post-renal causes due to obstruction: tumors, stones, obstructive uropathy, pelvic ureteric junction, PUJ obstruction, and posterior urethral wall. Post-renal causes is due to obstruction like tumors, stone, obstructive uropathy, like pelvic ureteric junction obstruction, PUJ, or PUV, posterior urethral wall. AKI management: pre-renal AKI and renal AKI. Pre-renal AKI, fluid repletion. Goal: restore circulating blood volume, 20 to 30 ml per kg of NS over 45 to 50 minutes. Responsive if urine output is more than 2 ml per kg. If follicula is persisting, diuretic, furosemide 1 to 1.5 mg per kg. So management of AKI is dependent if either the cause is pre-renal or renal. For pre-renal, you have to restore the circulating volume by giving normal saline, 20 to 30 ml per kg over 45 to 50 minutes, that is within 1 hour. If it is responsive, urine output will be increased by 2 ml per kg. If follicuria is persisting, then diuretics, furosemide 1 to 1.5 mg per kg. Renal AKI, fluid restriction. Goal is to prevent edema and further renal injury. Renal AKI, fluid restriction. The goal is to prevent edema and further renal injury. Fluid given: insensible water loss, 300 to 400 ml per meter square plus urine output. Goal is to prevent edema and further renal injury by doing if there is a renal AKI, fluid restriction, because goal is to prevent edema and further renal injury. Fluid given is insensible water loss, that is 300 to 400 ml per meter square, and plus urine output to just replace the flow water loss. Complications and management. Complications are anemia, metabolic acidosis, hyponatremia, and hyperkalemia. Hyperkalemia is when serum potassium is more than 5.5 milliequivalent per liter. Management: anemia. There is anemia due to hemodilation, usually resolves on management with fluids. Anemia is due to hemodilution, usually resolves on management with fluids. And also due to blood loss, you can give packed red. If it is due to blood loss, then you give packed red blood cell transfusion. Metabolic acidosis: in metabolic acidosis, you give IV sodium bicarb. Hyponatremia. Hyponatremia can be asymptomatic and symptomatic. If it is asymptomatic, resolves on fluid management. If it is asymptomatic, then it resolves on fluid management. Symptomatic, you give 3% saline hypertonic. 3% saline hypertonic. Hyperkalemia: serum potassium more than 5.5 milliequivalents per liter. You have to reduce potassium levels. Shift potassium intracellularly. You do it by insulin glucose drip, sodium bicarb, and nebulization by salbutamol. Increase potassium excretion binders, potassium binding resins like K-exalate sodium polystyrene sulfate, K-exalate sodium polystyrene sulfate. If refractory, then dialysis. High potassium: if more than 7 milliequivalent per liter, it can cause conduction abnormalities. Slow IV infusion of 10% calcium gluconate with cardiac monitoring. Fast infusion contraindicated due to effects on conduction. High potassium more than 7 milliequivalents per liter, there could be conduction abnormalities. So you have to give slow IV infusion of 10% calcium gluconate with cardiac monitoring. Fast infusion contraindicated due to effect on conduction, so very slow infusion. Hemolytic uremic syndrome types, D plus most common and D minus. D plus is, it means it is associated with diarrhea. D minus is not associated with diarrhea. So hemolytic uremic syndrome associated with diarrhea, which is most common, is due to Shiga toxin produced by Shigella dysentery type 1, enterohemorrhagic E. coli strain O157N5H7. So hemolytic uremic syndrome associated with diarrhea is most common, and it is due to Shiga toxin, and it is caused by Shigella dysentery type 1, Shigella dysentery type 1, and enterohemorrhagic E. coli strain O157H7, enterohemorrhagic E. coli, and Shigella dysentery type 1. Not associated with diarrhea. Defect in alternate complement pathway, reduce factor H. Defect in alternate complement pathway, reduce factor H, increase activation of complement pathway, increase activation of C5. If it is not associated with diarrhea, there could be a defect in alternate complement pathway like decrease factor H and increase activation of complement pathway, that is increase activation of C5. Pathogenesis of diarrhea associated hemolytic uremic syndrome. So here Shiga toxin, cytotoxin mediated injury, damage to renal parenchyma causes uremia, and then endothelial damage, fibrin deposition plus clot formation and causes hemolysis, renal parenchymal injury. Features: most common age group is less than 4 years. Most common presentation is diarrhea. 5 to 10 days you have pallor due to anemia, weakness, oliguria due to renal failure. Investigation on peripheral smears, you see schistocytes, lysed RBCs. So you do a peripheral smear, you do a blood investigations, increased blood urea and increased serum creatinine. You do Coombs test, which is negative, no antibodies. Coombs test is negative. PCR ELISA on stool samples for Shiga toxin is a definitive test. PCR ELISA on stool sample for Shiga toxin is a definitive test. Management: diarrhea associated hemolytic uremic syndrome. What do you do? It is usually self-resolving. You give supportive treatments. Contraindication: antibiotics, because it will cause lysis of bacteria and will increase toxins into blood. If it's severe, then you do dialysis. Diarrhea not associated negative hemolytic uremic syndrome, you give C5 inhibitors, blocks complement activation, eculizumab and rebulizumab. C5 inhibitors blocks competitive activation. C5 inhibitors blocks competitive activation, eculizumab and rebulizumab. If it's severe, then you go for dialysis. Chronic kidney disease. Chronic decline in renal function. Definition: GFR decline less than 60 ml per minute per 1.73 meter square for more than equal to 3 months, and persistent renal abnormalities, structural and laboratory, proteinuria, hematuria for more than equal to 3 months. Persistent renal abnormalities, structural or lab, and you see proteinuria or hematuria for more than 3 months, and GFR declining less than 60 ml per minute per 1.73 meter square for more than equal to 3 months. So that is the chronic decline in renal functions. A stage of chronic kidney disease is 1, 2, 3, 4 and 5. Stage 1 is hyperfiltration. GFR is more than 90 due to compensation by hypertrophy and surviving nephrons. Stage 2 is GFR 60 to 89. Stage 3 GFR 30 to 59. Stage 4 15 to 30. Stage 5 less than 15, or if patient is on dialysis. So stage 1 is hyperfiltration, where GFR is more than 90 because of hypertrophy of surviving nephrons. Stage 5 is when GFR is less than 15 or the patient is on dialysis already. Etiology of chronic kidney disease. There is a obstructive uropathy for like stones, tumors and strictures, stones, tumors and strictures. There is a reflex nephropathy like vesico-ureteric reflex causes scars in the kidney. Reflex nephropathy, vesico-ureteric reflex causing scars in the kidney. Chronic glomerulonephritis, IgA nephropathy, Berger's disease. Chronic glomerulonephritis, IgA nephropathy, Berger's disease, and congenital anomalies, which is most common. Congenital anomalies are most common. Another etiologies are obstructive uropathy, reflex nephropathy, chronic glomerulonephritis like IgA nephropathy, Berger's disease. Management: structural anomaly management, surgical correction. Irreversible, then medical management. No diet restriction, including proteins, to promote growth. Intake of polyunsaturated fatty acids, PUFAs, and complex carbohydrates. So if it is a structural cause, then you can go for surgical correction. If it is irreversible cause, then there is no diet restriction to promote growth and should take more PUFAs, polyunsaturated fatty acids, and complex carbs. Management of complications in chronic kidney disease. Complications are anemia, mineral bone disease, short stature, and hypertension. Anemia: when GFR is less than 30 ml per minute per 1.73 meters square, it is decreasing erythropoietin. Management: darbepoetin, subcutaneous injection, recombinant erythropoietin. We can give recombinant erythropoietin which the name is darbepoetin subcutaneous injection. Mineral bone diseases: due to decreased levels of 1 alpha hydroxylase, there is decreased active vitamin D levels, that is 125 dihydroxy vitamin D. There is hypocalcemia, there is secondary hyperparathyroidism, and there is bone resorption. So for you give calcitriol supplementation, that is active vitamin D supplementation, that is 125 dihydroxy vitamin D, active vitamin D, calcitriol. And if there is hypocalcemia, so calcium supplementation, and resolves upon treatment of um, vitamin D and vitamin and calcium. Hyperparathyroidism, which is secondary due to reduced calcium, that will also resolve by itself. Advanced chronic kidney disease, there is phosphate excretion and therefore there is hyperphosphatemia. There is reduced phosphate excretion. In advanced kidney disease, there is reduced phosphate excretion, and that's why there is hypophosphatemia. You can give phosphate binders. Calcium based is acetate and citrate, and non-calcium based is sevelamer. You can give phosphate binders. Calcium based is acetate and citrate, and non-calcium based is sevelamer. Short stature, you can give recombinant growth factor. Hypertension, lifestyle management, salt restriction less than 2 gram per day, exercise and weight management. Medical management is angiotensin converting enzyme ACE inhibitors and angiotensin receptor blockers, ARB. ACE inhibitors and ARB, angiotensin receptor blockers. Kidney replacement therapy, KRT. For progressive CKD refractory to medication, initiation at GFR less than 12 ml per minute per 1.73 meter square, you can go for dialysis. So for progressive chronic kidney disease which is refractory to medication, you can go for dialysis when GFR is less than 12 ml per minute per 1.73 meter square. Upon finding a donor, renal transplantation, that is the definitive treatment. And dialysis more accessible option than peritoneal dialysis or hemodialysis. Peritoneal dialysis is a home setup, approximately 12 hours per day, better hypertension control. Hemodialysis is a hospital setup, approximately 3 times per week for 3 to 4 hours each. So depending upon what's more accessible, you can go for dialysis. In the next session, we'll see vascular ureteric reflex and UTI management guidelines.